One thing that I'd be interested to know, because in 1983 the Society for Exploration of Psychotherapy Integration was formed, and I imagine that it was just a small group of dissidents, people who were thinking outside the box. How do you remember those days, those very early SEPI days?
The, that was really, those early days were pre-SEPI
Uh-huh.
because I think what happened was that Paul and Marv decided to form this organization after they worked together at Stony Brook.
Mhm.
And they each suggested some people who they knew, who they thought would be sympathetic with those goals and asked them to help. Um, I had known Marv since he and I were both graduate students, although we were students in separate schools. We had a common internship where we met, and that had been maybe 25 years earlier than the SEPI beginning, and we had worked on a book together.
Mhm.
So he and I are old friends. And so I was one of the people. Barry Wolf, who Marv had worked with in Washington, was another. And then there were some other people who were in and then dropped out. But the four of us, I think, were the core that really began and followed through
Yeah.
with the organization. We would meet maybe once every 6 weeks or so in Marv's apartment in New York, which was easy for Paul and I because we were New Yorkers and Barry flew in from Washington. And we would talk about what our goals were and how to go about meeting them. And then we formed a small um, potential membership list of people each of us knew and wrote to them and asked, and we got a tremendous response. Very few people, it was selective who we chose to write to, but very few people said no. Um, but the membership list in the beginning was less than 100.
Mhm.
And then the first meeting, I think, was 1985 in Annapolis.
Yeah.
And there were, I don't remember the numbers, but it was not large. And everyone there was elated that it was, we could now say out loud what at the time we were a little embarrassed to say to our colleagues, because that was a very school dominated time. And what we were talking about was heresy.
Yeah.
It was different heresies because Paul and I were psychodynamic and Marv was CBT and Barry was humanistic.
Mhm.
But uh, each of us felt that if we said it's like all of us knew we did things in therapy that we didn't tell our supervisors
Uh-huh.
because it would not be looked at very kindly. And I'm not sure, I don't even remember if I would suggest to my supervisees that they do some of the things that I was doing
Uh-huh.
because it was still enough outside the bounds.
Yeah.
But the meeting was very exciting, and then the organization began growing. And as it grew, it became more legitimate to take that kind of point of view. And we began to be able to say it out loud, to say we supported psychotherapy integration, that if I went to a psychodynamic meeting and I said integration, they would think, well, that means integrating classical work with object relations. But the idea that you could go outside of psychodynamic and integrate,
Was
they still
crazy.
look, yeah, they look funny at me. Uh,
So you actually made a way to come out as integrative.
that's right. That really is what it was, because we were all closet integrationists,
Mhm.
and it became okay to come out. And then the meetings grew larger, but they never really grew. I don't know that we ever had more than 300 people. Usually it's closer to 200. which I find very nice because you tend to see a core of the same people every year. Uh, you always get a big local turnout, and they may not be repeaters, but there's a core of people who you can almost count on seeing all the time. And so everything became very friendly. I think the next developmental step was probably in the probably when we started to have a journal.
Yeah.
Because that gave people an outlet for what they wanted to say.
Yeah.
And it was harder to publish in a traditional journal because it wasn't here or there. But when we had our own journal, that was an outlet for everyone who had something to say.
Yeah.
And then John and Marv on the one hand and Jerry Gold and I on the other both published handbooks in the early 1990s.
Yeah.
And I think that brought together a lot of the literature that had already existed. And then little by little, you began to see some programs have courses so that students could be educated above board instead of if they happen to be lucky enough to get a supervisor. I don't think to this day most schools have a course in integration. But where they have it, I know my students receive it extremely well. It's a popular course, and unlike my students of my generation, students of your generation have gotten to say, well, what's the big deal? Doesn't everyone exist?
Yeah.
Which is a very nice change.
Yeah, but you mentioned something interesting that could, in a way, help explain this, because in a way it seemed that everyone was a little integrative or eclectic, but no one really wanted to talk about it.
That's exactly right. So that it was very easy to tap into these people because we were hitting home. And
you created a safe space.
That's exactly what that first conference was. It was a safe space for everyone to say out loud what they had to think.
So in 1993, you did the Comprehensive Handbook of Psychotherapy Integration, and that was, I think, 1 year after the first Handbook of Psychotherapy Integration. I think it was in 1992 that Mark Goldfried. And at the time, you were really investing so much of your professional time in this cause. How did your surrounding, did you still go, for instance, to other psychodynamic, psychoanalytic conferences? And how did this blend? How did your colleagues react to this investment you were doing?
I still went to other conferences. At this point, I don't, but that's more a matter of age and I'm less inclined to travel than a lack of interest, because I still read in areas outside of just integration. And you really, there's a whole thing we can talk about as to the proper way to educate people to be integrationists. But my thought always is, if you don't know one or more areas well, you have nothing to integrate. So that I think the best way of doing it is giving school-based courses early in a program and then moving to integrative courses once the students have things that they know enough about to integrate.
Sure.
And so that would be the approach I would take, why I would continue then and now to learn other things, because I can then bring it into my work in an integrative way.
And you've always been interested in integrating research and practice, of course?
Right. So the integration for me, I always preferred a big tent instead of a little narrow group. Whether it's research and practice or it's different approaches to psychotherapy, I think anyone who stays narrow is going to miss a whole bunch of what's going on.
Maybe we can bridge what we're talking about with an approach that you devised called the local clinical scientist. Maybe you
Right.
can tell our viewers what that is.
Local clinical scientist is a way of bringing scientific thinking into the consulting room, which is the local part of it. And so when we approach a patient clinically, we're also approaching it with the curiosity and the hypothesis testing attitude that any scientist would have, and we learn from our work. I would hope that some people would end up publishing their observations or accumulating them, but that's not particularly likely. We have decades of research doctorates when people don't publish even their dissertations, so we know we're not going to get a lot of that. But they may, if they don't publish it, they may present it, they may pass it on in a supervisory role. But at least if they do it, then I'm comfortable with that. And so that idea of I think the metaphor we used was the Sherlock Holmes of the consulting room. That everything is to be looked at, to be learned from, but also to be tested. And one of the big hurdles is what we know about confirmation bias. So that if I look at a patient and I immediately have a hypothesis, this is a depressed person, it's a narcissistic person, then I'm going to find all kinds of supporting evidence, and I'm inclined to slough over disconfirming evidence.
Yeah.
And so that can be a problem, but if we're aware of it, it may help a little, at least in guarding against it.
You have a beautiful quote connecting to what you're saying in your book, How People Change. In the concluding chapter, you write something like, any attempt to impose our predetermined structure on a situation runs the risk of failing dismally. So I think that puts it very nicely.
Thank you. That, if you write a lot, as I have over the years, I end up having people say things like you just said, and my first thought is, gee, that's good. I wish I wrote that.
Yeah, who wrote that?
Yeah.
Isn't that a nice feeling in a way? Like, I did write that nicely.
There are times that I'll assign something that I wrote, and anytime I assign anything to my students, I reread it before class. And I'll look at it and I'll say, I'm glad I said that.
Wow, that's a great.
And so I'll say, why did I leave this out? And so then I use class as a way of saying, but wait a second, there's other stuff also.
Yeah.
We learn as we go on.
Of course.
And I think that's part of the heart of doing integration, that we learn as we go.
You were talking about the idea of the importance of testing hypotheses in therapy and seeing how things actually work. This actually seems very much in tune with the client-direct approach that's been going on, routine outcome monitoring that has had a big push in the last decade. I remember something funny when you edited the casebook of psychotherapy integration.
Right.
I remember that you write there that at first you were excited to get the text from the people, but then when you try to organize it in the different categories of integration, like which ones are common factors, which ones are assimilative, it wasn't actually that easy to do.
I think the expression I might have used is, if not there, somewhere else, very fuzzy boundaries. That we have clear definitions we could lecture about of the four approaches. But when you see them, it's not all that clear.
Yeah.
Like Arnie Lazarus insists that what he's doing is technical integration and that it's all based on social learning theory. Why that isn't assimilative, I don't know. And I don't think it really matters. It's clearly integrative. What you call it is helpful to us perhaps in organizing things, but he knew what he was doing.
Yeah.
And so what name you call it is less important.
Even though from a scientist standpoint, I do imagine it could concern you to have different categories that actually are not completely separate or can be confluent.
It would be much cleaner if they were separate,
Mm-hmm.
but if they're not, it also tells us something.
Mm-hmm.
And our categories don't carve nature at its joints. And that being the case, I think we're better off acknowledging fuzziness than forcing things into categories.
I like that. Could be a good title for a book, Acknowledging Fuzziness. That sounds great to me. Well, and even the most recent therapies like emotion-focused therapy, acceptance and commitment therapy, they are in a way integrative. And psychodynamic therapies and CBT along the time have incorporated, of course, different influences. So in a way, if everything is integrative, what's the function of the integrative movement today for you?
That's a really good question, because I think the hot thing now in CBT is what they call third wave.
Mm-hmm.
And third wave is a very integrative way of building on a core CBT approach.
Mm-hmm.
I think CBT, in fact, itself is an integrative approach, even though we look at it as a school,
Mm-hmm.
but it integrated cognitive therapy with the earlier behavior therapy.
Mm-hmm.
One of the problems of that is that the more C there was, the less B there was. And I think behavior gets overlooked much more than it should, as it always had been by psychodynamic thinkers.
Yeah.
So that's something that I think everyone ought to pay more attention to.
Yeah.
One of the function, I think before we ask what is the function of integrative today when everyone is doing it, we first have to think about what's the function of a school. Because if it's clear what the function of a school is, and it's also clear why we need to continue to be integrative.
Yeah.
And for a school, I think what it often serves, if you can think back to when you were a first-year graduate student and didn't know what was going on, what you wanted most of all was to tell you the right way of doing things.
Yeah.
And that's what a school does for you. It gives you a clear framework, and if you do this, you'll know what's going on, and you won't feel so helpless and so bemused by everything.
So it's a safety net for the therapist in a way.
It's very much a safety net for the beginning therapist.
Yeah.
And then the minute you join a club, insider, there have to be outsiders. So as soon as you become the good guy, you have to note who the bad guys are.
Who's not following it by the book.
Right. And so those are, if you're a CBT person, the psychodynamic people, not only do you know what's going on, but the psychodynamic people don't, and vice versa.
Yeah.
So then you call each other names, like fuzzy-headed or narrow or whatever.
Yeah, it's social psychology in a way. It's
exactly.
Yeah.
Well, that's another interesting point, because one of the things we tend not to integrate enough is basic psychological knowledge.
For sure. Yeah.
Like before, I referred to confirmation bias,
Yeah.
and that's not a clinical term. That comes from basic cognitive research, and yet it really has implications. So if we don't know developmental research, social research, cognitive research,
yeah,
we are less effective in our work as psychotherapists.
Mm-hmm. Mm-hmm.
So what is the purpose of integration now? We still need to break down the boundaries that new people adopt as safety nets, as security blankets.
Mm-hmm. Mm-hmm.
And So to tell somebody who's learned this is the right way to do it, well, it's a right way to do it. And maybe there are other right ways also. And maybe what's important is not what makes you feel comfortable, but what makes the patient feel better. And that in order to get to there, you need to think there are more things on heaven and earth ratio.
I imagine this is a question, kind of cliche question, but do you actually believe in a future where it's possible to train therapists without a school mentality?
It would be very interesting to see if you could teach them the various schools without indoctrinating them in the school. Mm-hmm. And that would be the trick. Is it possible? I don't know about European education. In American education, I think it's much less likely because a school has a reputation for doing something. Stony Brook, where Marv is, has a reputation for teaching CBT.
Yeah.
Adelphi, where I was before I moved, and CCNY, where Paul is, have reputations for being psychodynamic. Mm-hmm. What that means is that we attract students who are attracted to those things. We choose faculty members mm-hmm. who are aligned with that group. What you would really need is to develop a program that would make a conscious effort to select faculty members. Mm-hmm. And I don't see that happening very soon here because there's such a payoff for being aligned with a school.
Yeah. The benefits are still too big.
And so I think the political outweigh the pedagogical.
Yeah. Uh-huh. And this recent push towards evidence-based practice, do you think it has helped or hindered integration? Probably not an either-or question.
Well, I think evidence-based practice should help any kind of therapy, but evidence-based practice is not synonymous with empirically supported treatment. Mm-hmm. And I think that's the mistake a lot of people make.
Yeah.
That, of course, you're going to want evidence-based practice. What do you want, magic-based practice?
Uh-huh.
But the question is, what is evidence?
Yeah.
And if evidence is simply a randomized controlled trial, mm-hmm. I think it's neither accurate nor very useful for integrative work where you really can't do mm-hmm. a randomized trial. You really can't have a manual mm-hmm. Because the flexibility in the practice is its hallmark. But if you're looking for evidence, wherever it may come from, then I think, of course, you'd want that. You mentioned before, I think one of the most important programs of research now began with Mike Lambert and the outcome assessment work, mm-hmm. which I'm really astonished how few people have adopted it.
Yeah.
Because it's very easy to implement in your practice, and the results of the research are so overwhelmingly convincing mm-hmm. that this is something that could be really helpful.
Mm-hmm. But still progress is slow.
Very slow. And for some people, kicking and screaming. They go.
Uh-huh. Well, talking about people kicking and screaming, I would still like to talk a little bit about your own model of assimilative psychodynamic psychotherapy.
Right.
And maybe you could mention, just for people to get a brief perspective on the 3 tiers that this model has.
Right. Well, let me take a step back from that.
Of course, yeah.
The assimilative psychodynamic model is what assimilative integration in general says. You start with a particular theoretical framework, and then you assimilate into that um, approaches other than from that model. So our work begins with relational psychotherapy, relational psychodynamic psychotherapy, and then incorporates all kinds of other things. To do chair work, which you would get from humanism, to give homework, which someone might do from CBT, to do routine outcome assessment would be something I would encourage my students to do, and I do myself all the time. Mm-hmm. So that's the assimilative integrative model. Anytime you do assimilation, and we go back now to basic psychology and to Piaget, if you assimilate, you also have to accommodate. The question is, if my model didn't call for these approaches and I find them effective, what's wrong with my model? And how can the model change so that it makes sense that you do this rather than it be something different that you're bringing in? And that's where the 3-tier model comes in, where we look at the individual as having these 3 tiers of functioning. I look at it as a triangle where the top of the triangle is behavior. And behavior might be like the tip of the iceberg as well as the top of the triangle. And the middle tier is conscious experience, which would be cognition and perception and affect, all that sort of thing. And then the foundation, which betrays my psychodynamic background, would be more unconscious and psychodynamic material. But the implication of that is that each one, any intervention reverberates. And so anything you do anywhere will affect the other tiers as well.
They're interconnected.
Right. Uh-huh. And so if I prefer to work with unconscious material, it's got to be with the expectation that doing that is going to affect conscious experience and in turn affect behavior. And since the patient, every once in a while I'll get a psychoanalytic candidate who really wants to understand their unconscious. But most people come in because they're hurting. Mm-hmm. And so self-understanding is going to be, if anything, a path toward accomplishing what they came for rather than an exercise just in its own right. And so it's my obligation also to make sure that whatever we do in one tier gets translated into the other. Mm-hmm. It also means that if I choose to do something that's a behavioral intervention, I expect it is going to reverberate in the other direction, and so it's okay to do that. Mm-hmm. It's not simply like a trickle up. If I do something here, it will ultimately affect the other 2 tiers. But you could enter at all 3 tiers and expect it to affect all 3, and in fact, a whole human being consists of all 3. Yeah. Then there is an expansion of that model that I wrote about in my recent book, which takes into account that this triangle, this 3-tier that we've described, and when I say we, it means Jerry Gold and I, because Jerry was also intimately involved in this, that the 3-tier model, that triangle, lives in a world with a lot of other triangles. And so it's not only the intrapsychic or intrapersonal stuff that goes on within the 3 tiers, but how the triangle affects other triangles and is affected by those triangles. Mm-hmm. So you add the relational component. Yeah. And then I put a big circle around the whole thing, which takes account that all of this interrelating occurs in a larger cultural context. Yeah. And so then you've got the whole ball of wax. I think the original triangle was limited by looking at a one-person psychology and how do we understand the individual. Mm-hmm. and that expanding it to include other triangles and a cultural context is a more two-person and a more realistic way
Yeah.
looking at all of our influences.
It does seem like the evolution that happened within psychodynamic therapy towards more relational elements, and even the criticism that behaviors used to do towards psychoanalysis, that the environment wasn't taken into account enough.
And they were right.
Yeah. It's interesting that in your own work I never felt that, and I feel that you tried to make a big balance between the various elements. I even remember that you wrote that if the environment does not support the client's change, they are unlikely to last. So,
Exactly.
yeah. And this...
Well,
yeah, go ahead.
any of us who work with children, I tend not to, but any of us who work with children know it doesn't matter what you do with the child if you can't affect the parents.
Yeah.
Because you're sending the kid back to the same environment that produced the problem. The same thing is true of adults. If you are in a troubled marriage, you could help the individual to grow and then send them back to the same marriage where there'll be all of the forces to bring him back into equilibrium. Same thing with addictive behavior, that if you go back to the same environment with the same friends, you're going to end up doing the same things. So you've really got to take the larger context into account, or you're not going to be very effective.
So trying to bridge this from the theory to the practice, one of the things that you wrote about is the possibility of incorporating homework in psychodynamic practice. I laughed and I was surprised when you wrote that it probably happens more frequently than psychodynamic therapists think or recognize.
Right.
How did you come to this idea?
Because I know how I practice.
And you know how your colleagues practice also.
That's right. And I know, for instance, that dreams, I think, are valuable. And if I mention that to a patient, they'd say, I don't remember my dreams. And I might say, well, you might try putting a pad on your nightstand and writing them down. That's homework.
Homework, yeah.
Or in a more subtle way, I might start an intervention by saying something like, I wonder what would happen if. And almost always if I say that, the response is, do you think I should?
So very smooth way.
It's a suggestion. Without saying, why don't you, or you should.
Yeah.
The responsibility is yours, but here's something to think about that you may want to do. That's homework, even if it's a psychodynamic intervention.
Yeah.
So to give more explicit homework is just stretching the boundaries a little. It's not a brand new thing.
And you didn't find this. You needed the assimilative part. You didn't find this in your original context of psychodynamic therapy.
Not clearly given homework. The subtle homework, the implied homework was always there. But the clear homework wasn't.
I'm sorry for jumping around a little, but now I'm still curious of another area of your work, which is the self-disclosure part.
That's way early, yes.
That's way early. 1990, you did the self-disclosure, the book, and you continue to write about that. What drew your interest to this topic?
I think that's a major question in therapy for anyone, particularly for psychodynamic therapists. And as more classical people, and when I was trained, classical was virtually the only game in town. So that's how you had to be trained. But as you took more into account relational approaches, which I now find the most helpful, you really have to face the question of what is it appropriate for me to say to the patient about myself.
Yeah.
And in the early days, the answer probably was nothing.
Blank screen.
Blank screen, which is never blank.
Exactly.
So that whole thing was a fiction to begin with. Well, if I had a patient walk in today looking at me dressed as I am,
Mhm.
and you had a patient walk in and looking at you dressed as you are,
Mhm.
with your being obviously younger than me, you're having a beard and I don't, they have different impressions of us immediately. That's self-disclosure.
Sure.
So then the question, it's the same as homework and what's implied and then what do you make overt. With self-disclosure, what has to be there?
Yeah.
Because you're not, even if you're, let's say how your office is decorated. We have different types of artwork. What does that say about us?
Mhm.
Somebody may say, I don't want to tell anything, so I have no artwork. Well, what does that say about us?
And what do the clients project into that?
Right.
Yeah.
So that you're always
Saying something.
yeah, I call them patients, you call them clients. They're the same people.
Yeah. Uh-huh.
But patients want to know about us.
Sure.
So they're always filling in the blanks, and the blanker we are, the more they fill in,
Yeah.
which is part of the theory of transference.
Yeah.
Let them fill in. But sometimes we give them hints that we don't acknowledge.
Mm-hmm.
And so that's how I got interested in self-disclosure and what is it appropriate to say and what still is it appropriate not to say. What should we be cautious about saying? Because it isn't a friendship.
Yeah. It seems again like it came right out of from the same motivation that brought you to the integration part, which is wanting to expand your original vision of what psychotherapy is about.
That's right. Mm-hmm. What the world is about.
What the world is about, sure. But there is one thing that I found very interesting, and I have to highlight this question. When you wrote about this in 2003 in an article, you wrote that disclosure could be memorable, it could be dramatic, but does it lead to change? And this is the question, right?
That's an excellent question, not only about disclosure, but about anything we do. There was, do you remember, you don't remember, but have you, because it's before your time, but do you know about what was called the encounter movement?
Of course. Esalan Institute,
right.
Fritz Perls going around shouting at people.
And the experience at that time, and eventually the research at that time, was very clear that if somebody went to an encounter group, if you measured immediately after the group, it was a great high and people loved it. Uh-huh. Occasionally people were damaged by it, but most of the time they loved it. Uh-huh. If you checked in 6 months later, they were back to where they started.
I have to admit, it sounds a little bit like Freud coming from the grave, like, the ab reaction didn't work.
And it doesn't, unless what it works is if you then follow up and deal with whatever emerged from that experience and help them to come to terms with it, to integrate it, and to use it constructively.
Yeah, like processing.
But just one cathartic experience is not going to have long-lasting effect.
It's really interesting, and again, I feel the need to bridge with one other little thing, because you also wrote about failures in psychodynamic practice, and
I wrote about psychodynamic because that's what I do.
Yeah.
But there are failures in all practice.
Yeah, of course. Yeah. You talked about the failures you know best about.
Right.
And when you wrote the article with Jerry Gold, there was one point there that I really feel from the literature is not talked so much, which is therapist burnout.
Mm-hmm.
That this could also have implications. And I wonder if you could talk to us a little bit about your own thoughts of therapist self-care and burnout and its implications to therapy failure.
Let me try to organize this in my mind now.
Of course.
the way I got into this in the first place, into focusing on therapist failures.
Mm-hmm.
And a therapist failure isn't a therapist mistake.
Yeah.
Therapist mistakes all of us make all the time. That's what's at the heart of the theory of therapeutic ruptures.
Mm-hmm.
And if we are able to identify and heal those ruptures, they're constructive. Therapist failures is when, despite our effect, the patient ends up either no better or much or worse than when they started. Yeah. And that's what I'm concerned about.
Yeah.
I also was always amused, and amused may not be the right word, that all of our students, not only did they feel they didn't know anything, and they really didn't when they entered the program, but feel overwhelmed by everything. But everything they ever read were about brilliant therapists having success.
Uh-huh.
And weren't.
Mm-hmm.
And there was a disconnect to that made them feel even more inadequate. But who's going to write about anything but a success? Uh-huh. So, of course, that's how they would feel. And that's why I felt it important to write about failures, to say to those students, look, it doesn't always work the way we want it to. And even the most experienced people will have this happen and not always be willing to acknowledge it.
Yeah.
I remember I approached somebody to write something for us who said, I can't do that. I have no failures.
Oh, wow.
Well, that's nonsense. That means I have no insight.
Yeah. Mm-hmm.
Because of course he has failures, and there's nothing wrong with having them.
Yeah.
We're not happy with it, but those things happen. And if we can acknowledge it, we could learn from it.
Yeah.
If we think they're not failures, we learn nothing.
Yeah. Mm-hmm.
Now, how does that connect to what? Where did we start?
I was asking about the self-care part and the therapist burnout.
Right. And that also, I think therapist burnout very often comes from a growing sense of lack of satisfaction with one's work.
Uh-huh.
And because I can work very hard, as long as I feel I'm accomplishing something, it doesn't bother me. Mm-hmm. As soon as I feel that I'm pushing a rock uphill and it's rolling back down on me, then burnout is very easy. Yeah. So the question then becomes, how do you keep people feeling that what they're doing is meaningful, that they're getting the kind of results that they're happy with? Yeah. And I think that prevents burnout. And one of the things that connects the two is not everything I do is wonderful. And that's okay. Mm-hmm. Because that's true of everybody. Mm-hmm. And if on balance, I end up making a contribution, then I've done my job, I can be proud, and I can keep going. But if all I think about is, damn it, missed it again, then after a while I'm going to stop doing it. That may be one of the reasons why it is so difficult to have a suicidal patient. Mm-hmm. Because that's the most dramatic failure that anyone could have. And other than our sense of empathy for the loss, there's also the sense of failure. Yeah. And what could I have done differently? Mm-hmm. And so a lot of people get so discouraged, and I don't want to say they should just dismiss it. They certainly shouldn't. Mm-hmm. But if you're dealing with people's lives, sometimes they don't go right.
Yeah. Shit happens.
Yeah.
Yeah. But
I don't think I ever wrote that.
Well, there's an idea for a future paper.
Right.
But I have to say that it's interesting that what you just said, in itself, it's very therapeutic, I think. That also the therapist is fallible, not perfect. And I think even I would expect if a client actually feels that, even from the therapist, it can be quite a powerful message in a way.
Well, if I have a patient who feels that there are ways in which I'm not perfect, then there are also ways that it's okay for him not to be perfect.
Exactly. If the therapist accepts being imperfect.
Right.
Yeah.
And we are, so we might as well accept it.
Sure.
Occasionally in marking, we give our students comprehensive exams.
Mm-hmm.
And occasionally what they will write, because they know about how important it is to heal ruptures, they know how important it is for the patient to have, to see that a therapist who's so revered could do something wrong and be okay anyway. And so they'll write something like, because of this, I'll purposely make a mistake so that the client can learn from. You don't have to make it purposely. You're going to do it easy.
There is no practice needed.
That's right. We all do it.
Of course, yeah.
The important thing is recognizing it, learning from it, trying not to repeat it too many times, and heal whatever problems we've caused by doing it. Mm-hmm. And then the lesson that is learned is it's okay for me to make mistakes. It's okay for me to tolerate mistakes from other people, that this is part of being human, rather than having expectations of perfection, either with myself or anyone else.
You know, George, the last question I wanted to ask you, and you already outlined it so beautifully, but I'm still going to ask just for the sake of being explicit, because I've been asking it to all of our colleagues anyway, which is, what advice would you wish to have received when you were starting out your own therapy practice?
Relax.
That's the bottle you'd send?
That's it. You're going to be okay. Take it easy. Mm-hmm. Learn whatever you can. Be curious all the time. But don't hold yourself to impossible standards. Don't make it clear that you're doomed to fail before you start, by setting the bar so high that nobody could exceed it.
It reminds me of the Samuel Beckett quote, "Fail again and fail better."
He did have a few things to say.
Well, George, I also learned a lot from you, so I'd just like to tell you thank you so much for the opportunity of talking.
Oh, it's been a pleasure. I appreciate the chance to do it.